So to finish up our discussion on chapter 9, we started that chapter before spring break. If you recall, it was trauma focused, and then also including dissociative disorders. So we made it through all the way to this slide. We left off specifically talking about dissociative identity disorder and the different alternate personalities in which someone can experience with that particular disorder. So, if you guys recall, we watched a video of a couple individuals that were suffering from dissociative identity disorder. Specifically, Christine, if you remember, she had 16 different personalities, and they all had their own very individual characteristics. They were very fluid in which they presented. So when we think about those different alternate personalities, how do they differ among each other? And how do folks with dissociative identity disorder differ when we think about that and how this disorder is expressed within them? So really, Christine was a great case study for you all to have experienced and watched in that video, because you could see that they each different alternative personality had specific identifying features. One personality was a young child, so her voice changed drastically when that child personality was coming through. She also engaged in like thumb sucking behavior, or had her thumb near her, and how she interacted with her husband and other folks really assumed that role. Also, specifically between those differences, those vast differences in her personalities, you could see different abilities and specific preferences that those personalities had. One, I believe they alluded to as kind of the overbearing or strong-willed individual, and they also referred to her as a lesbian. So, based on these different features of each of those, you can see how they're expressed, and then also physiological responses. So again, voice, mannerisms, and those types of things. Okay. So how do these different personalities interact with each other? Well, as you saw in the video, you saw that Christine's were very fluid with each other, and they even talked to each other. There was interaction amongst those different personalities. Okay. When we think about DID, or dissociative identity disorder, there are three kinds of relationships here noted on your PowerPoint slide. So one, the mutually amnesic relationship. So what is that? When you have subpersonalities that have no awareness of one another. Okay, so you have the main personality, obviously the person, and then you have all the other subpersonalities. Those subpersonalities do not know, they're not aware of any other personalities. Okay, they have no idea. So therefore, the interaction would be limited. Obviously none, there would be no interaction with them. The other kind of relationship is the mutually cognizant patterns. Okay, each subpersonality here is well aware of the rest of the personalities that the individual has. Okay, so this would be very descriptive of Christine. So the mutually cognizant patterns. And then the last one is the one-way amnesic amnesic relationship. This is the most common, typically. Some personalities are aware of others, but the awareness is not mutual. Okay, so one personality might be aware of another personality, but that other personality does not know about the other personality. Okay, so not mutually exclusive. It's a one-way pattern. So think about that. So when we're looking at the DSM-5 criteria for DID, it's a very lengthy definition, a lot of things that must be considered when we're looking at this diagnosis. So First and foremost, there has to be a disruption of the identity characterized by two or more distinct personality states. Okay, so what does that mean? Changes in behavior, affect, consciousness, the memory component, how they're perceiving things, cognition, sensory motor functioning, those types of things. So there has to be some type of identity, disruption of identity characterized by those different changes. Okay. Secondly, gaps in the recall of everyday events, important personal information, traumatic events that are inconsistent with ordinary forgetting. Okay, so we're talking about when this individual is the personalities are coming in and out is causing these memory gaps for these folks. And again, like it says, not just simply forgetting, clearly unaware of different things that have happened to that individual. So if you recall back to Christine's video, there was one personality, I can't remember, but she actually turned on the other personality. So Christine inadvertently got hurt. I think there was some cutting, or I can't remember everything that was involved in it, but there was physical harm that happened. That person not knowing why that harm happened or how that harm happened can relate to this particular area of diagnosis. Significant distress or impairment, obviously. Disturbance, it's not a normal part of the broadly accepted cultural or religious practices, okay? So the behavior and the disturbance and the experiences that the individual is having, it is clearly out of the norm, obviously for society, and also in consideration of their culture and religious practices, all right? And then the symptoms, not attributable to the physiological effects of the substance or medical condition. Okay, symptoms are not attributable to the physiological effects of a substance or medical condition. So these expression of different personalities is not caused by a particular substance, so maybe a drug or something that the individual is taking, or a particular medical condition. Okay, so very important things that have to be considered when we're looking at that. So other dissociative disorders, depersonalization, derealization disorder, this is the persistent experiences of depersonalization or derealization, all right? So what is depersonalization? Having experiences of being outside of your body or an unreal sense of self, okay? And then derealization is really basically the detachment from your surroundings. Okay, so think of reality, derealization, not being connected to your surroundings, your environment, and reality in that way. Dissociative amnesia, quite interesting. This is where people are unable to recall important information, usually of some type of upsetting nature, and it causes them to be upset. This information is very specific to their lives. However, these folks are unable to recall this information, maybe who their parents were or where they grew up, right? This is a period in time where they're suffering this amnesia spell or experience for them. Okay, again, it's not just memory loss, it's not losing your memory, it's not forgetting, it's clearly just not being able to recall something very important and specific to their lives, and then inadvertently causing them distress because of that. Okay. Okay, so how do we support folks with theories and treatment? So certainly there are biological ways and causes, underlying factors related to trauma that are very complex in nature. And when we think about it, there are multiple systems that are involved that have to be considered. when we're trying to develop an appropriate treatment plan for this. Okay, so when we look at the research out there, guys, the research is pointing to an abnormal neurotransmitter, the process or the activity of the abnormal neurotransmitter, and also hormone activity. So how the individual's biological responses are. So when we're looking at the specific neurotransmitters, we're looking at norepinephrine and cortisol for these folks. Okay, so research is pointing specifically to those. Now, what do we do about this? I mean, obviously, it's a biological foundation, a biological component to the etiology of this disorder, and quite frankly, again, we see that genetic predisposition, the strong genetic predisposition that's related to this. So it's hard to combat or to help, but through medication, in conjunction with therapeutic approaches, it is very, very helpful. So, excuse me. With trauma, okay, guys, so don't forget that trauma is a common factor here. Obviously, trauma-related disorders and DID, dissociative disorders, that is that common theme there. And what we learned about stress and trauma is that it ignites arousal, right? That when the body is traumatized, when they experience stressful situations, you have those biological responses, biochemical arousal, right? And when you have repeated exposure or trauma or stress disorders, you consistently, what we're seeing is that some folks are having some damage, specifically in the hippocampus area and the amygdala area in the brain, right? So similar to stress, when people's levels of stress are higher and higher, and they continually have that or are exposed to that, we see, those different factors impact them, impact their responses, their biological responses. So keep that in mind when we're thinking about this and how that can impact that person in a very in a lifelong way for these. So for post-traumatic stress disorder, when we're looking at pharmacology, what they have found, antidepressants, benzodiazepines, mood stabilizers, and antipsychotics have all been used in the treatment of folks with PSD, okay? This wide range of different medications are used in order to specifically target symptoms that folks are experiencing, okay? And that varies from person to person. So again, why that is because all of those listed is because of the wide range of symptoms that folks can experience, okay? For DID, we see antidepressants, mood stabilizers, and benzodiazepines are most frequently used. Now, biological approaches are very important in conjunction with psychological treatments and supports, okay? So when we think about theories and supports related to that, the PTSD psychological theories specifically focus on personality factors of the individual, right? Is the individual more prone, have a more anxious approach, more anxious individual, a worrisome person, those types of things. So risk factors of high anxiety and negative worldviews. Okay, those are big things. A lot of times these folks lack those positive attitudes, so resiliency and hardiness to help protect against stress disorders, right? In addition to that, childhood experiences, impoverished childhood, traumatic childhood, psychological disorders, assaults, rape, abuse, anything that happens, some type of catastrophic event or experience at such an early age, at a young age, has tremendous impact on the development of such disorder and disorders. All right, as you saw in the video with Christine, she had a very, very traumatic childhood, and it was continued, and she was re-exposed to it over and over and over again. So again, these are very similar things or themes, if you will, for each particular disorder that we're talking about here. For DID, the psychodynamic perspective really takes hold here, meaning the psychodynamic perspective, again, is connected with Freud. Freud's big main theme in his research, in his theory, and in his approach was that people had, because of unconscious thoughts, these were behaviors, and the abnormal behavior were being expressed because of that. So for DID, the psychodynamic approach states or comes from the perspective that folks have repressed feelings, trauma, stress, those types of things. And because they have repressed that, then you see the development of different personalities used to help cope with the repression of those factors, okay, related to that, in order to combat and protect themselves. They repress those memories and feelings. Okay, now compared to the behavioral perspectives, they believe that disassociation for folks with DID, it grows from normal memory, so being able to understand everything, remember it, recall it, so normal memory processes, and it's a response learned through operant conditioning. So those behaviors or the personalities which are being expressed are used and have been developed through that operant conditioning process. So for example, like momentary forgetting of trauma leads to a drop in anxiety, okay, so they feel better, which increases the likelihood of future forgetting, okay. It's a very cumbersome process in trying to understand that. Now remember, DID, we're talking about a very small population of folks diagnosed with this. So there's limited information, but what we do know and what we're trying to understand is how these different psychologists are conceptualizing these different disorders from theoretical approaches, all right? So a lot of continued research that needs to be done in order to grow the toolbox, if you will, for this particular disorder, specifically DID, okay? So how do we treat folks? Prolonged exposure, okay? Exposing them to memories, to situations, re-experiencing those painful memories to help them process, right? Exposing them to the pain, to the memory, so they can work through that with someone there helping them in that process. Eye movement desensitization and reprocessing. So EMDR is something that is used where therapy, consists of exposing the client to or attending to the memory, remembering it, and then using different stimulus attempts to negatively reinforce or escape those avoidance behaviors, okay? Virtual reality therapy is another one. And then for DID, folks, and helping them recognize the disorder, recovering those memories, and then integrating those subpersonalities. So integrating them, so trying to get them to gain awareness of each other, helping the main personality understand the subpersonalities, and then try to create a very a congruent relationship and environment with those different personalities. So very challenging, but also it's challenging, but it can be very rewarding and just takes time on the therapist part and as well as the individual. Okay. All right, we will stop there for chapter 9.